Good evening, and welcome to the final round of the Capstone presentations by the inaugural class of Doctor of Health Administration cohort. To the inaugural class, to the extraordinary faculty who teach in the program, to the exceptional staff in the MSM Online division. My name is David Hefner, and I have been given the honor of leading and growing MSM's online and continuing education portfolio, giving it the form and function it needs for global scale. I have served at MSM for 10 years, first as chief of staff and then as the vice president and chief strategist, leading transformational growth at MSM. For nearly 50 years, in 1975, MSM was founded and enrolled its first MD class of 24 students in 1978. 13 years later, in 1991, we launched our PhD program and graduated our first PhD students in 1998. Nearly 25 years later, MSM launched its third doctoral degree, the Doctor of Health Administration degree, and this cohort of 12 will graduate May 17th, 2025 in the historical inaugural class of DHA graduates. I want each of you to understand the history and the legacy that you will carry and to some extent bear. Though each of you have already achieved significant accolades, there are even greater and higher expectations that come with having a degree from Morehouse School of Medicine. And yet, you did not come this far to disappoint. Indeed, you were chosen for such a time as this. As administrators, our job is to solve problems so that the business of education, healthcare, and wellness can ensue. Our job is to serve in excellence regardless of who gets the credit. At times, it may take making a way out of no way at all. To this historic inaugural class, I salute you and I affirm that you all will be ready. Congratulations, and I look forward to meeting each of you in May. Thank you.
Dr. Waldrop, you're muted.
Thank you. Good evening, everyone, and welcome to this evening's Spring 2025 DHA Capstone Oral Presentations. I am Renetta Waldrop, Associate Professor and Inaugural Program Director for the DHA program, also currently serving as an Interim Dean for Online Education and Expanded Programs. Tonight, our Cohort 1 scholars who entered the DHA program in the fall of 2022 will complete the last assignment and presentation of their 3-year doctoral journey. Their culminating project, a solution-focused capstone, will showcase their ability to identify a problem related to healthcare and to research and recommend a solution that is industry feasible, patient-centered, and administratively sound. Tonight, in TED Talk style, you will hear only a fraction of their research. A compelling story first that sets the stage for the problem itself. A statement of the problem and its magnitude, what the literature has taught them and revealed, and their recommended solution. For those of you wanting to learn more, their full capstone research project in the form of a white paper will be made available in a digital repository through the MSM library. For that, I want to thank Mr. Swanson, Dr. Lynn Simpson, and Mr. Wellmaker for making this option available. I also want to thank all of our DHA faculty and OEEP staff who supported our scholars, and in particular, those faculty who served as capstone coaches, guiding our scholars to the final stage of this journey, as well as the subject matter experts who provided industry relevant advice. Thank you also to Ms. Blake Crosby for making this virtual presentation platform possible. On this, our last night of presentations, let me give two more important thank yous. First, to Dr. Angelita Howard, the founding dean for online education and expanded programs here at Morehouse School of Medicine, whose vision for a DHA program, as well as her acceptance of me as the inaugural program director, has brought us to where we are tonight. I also want to thank Dr. Cheryl Houston, who was an adjunct faculty instructor here in the DHA program, and whose consummate help with me to develop the solution-focused capstone course plans, as well as her vision for our oral presentations to be TED Talk style, is why we are here tonight with these wonderful presentations that we have seen over the last 2 weeks. Tonight's presenting scholars will be Ariana Birch, who will be followed by Afia Saeed, who will be followed by Rochelle Johnson. The audience will be able to enter questions for our presenters in the chat. Following the last presenter, audience questions will be fielded by Dr. David Miles, our program manager. Q&A will be followed by Dr. Dorothy Boldrick, our DHA assistant professor, who has been with this cohort since day one in the program. That, my friends, was only a mere 934 days ago. Dr. Boldrick will give us closing remarks. Thank you all for being here and for your support of our DHA scholars. Ms. Birch, your TED Talk audience awaits, and the virtual TED Talk stage is yours. Thank you, everyone.
Hello, my name is Ariana Birch, and I will be presenting Analyzing the Influence of Social Determinants on Maternal Health Outcomes and Care Quality for African American Women in Rural Florida, Approaches to Address Disparities. Envision carrying life inside of you and feeling the joys and excitement of motherhood, only to discover the very healthcare system that is meant to protect you and your child, it might actually cause the greatest risks to you and your child's survival. For numerous African American women in Florida, this joy is eclipsed by the distressing and inequitable reality characterized by the markedly elevated risk of maternal mortality, related complications compared to their white counterparts. This is the very thing that occurred for Crystal Galloway, affectionately known as Chrissy. She gave birth to baby Jacob via C-section, and she experienced headaches and rashes all throughout her pregnancy. Nothing was prescribed to Chrissy due to her Medicaid non-coverage. She was told to take Tylenol. Even after she gave birth to her son, she experienced even more complications. 911 was called, and the Hillsborough County Fire Rescue refused to treat Chrissy. They said she looked as if she had too much to drink. They refused to even take her vitals as her mother pleaded for them to do something to help her daughter. Chrissy's mother had to make the ultimate decision to drive her daughter to the hospital, where she later died of an aneurysm 5 days later. This is only merely 12 days after Chrissy gave birth to baby Jacob. The lawsuit that was settled said her death was due to negligence. So I know you're asking, what is maternal mortality? Maternal mortality denotes the death of a woman during pregnancy, childbirth, or within 42 days postpartum, attributable to complications associated with the pregnancy or its management. This may occur due to multiple factors, such as medical complications during labor, exacerbation of pre-existing health conditions by pregnancy, or issues including bleeding, infections, high blood pressure, or childbirth related complications like obstructed labor. Maternal mortality serves as a critical indicator of our nation's health system, encapsulating access to quality health care, the capacity to manage these complications, and influence of social and economic determinants on maternal health. I'm here to discuss a topic that affects millions of women in this nation, but is sometimes overlooked. Black women's health and well-being, especially concerning maternal mortality. Black women are 3 times more likely to die from pregnancy-related causes than white women. This issue isn't just medical, it's social, economic, and systemic. The prevailing conditions resulting in maternal mortality rate in Florida that ranks among the highest in the nation for Black women. Racial disparity is closely linked to structural racism, healthcare inequalities, and implicit bias in medical care. African American women frequently encounter discrimination within healthcare environments, resulting in misdiagnosis, delayed treatment, and the underestimation of their symptoms, all of which are due to elevated maternal mortality rates. Furthermore, socioeconomic factors such as access to quality prenatal care and postnatal follow up intensify these issues. According to the Census Bureau, 41.57 million Black or African American people reside in the United States as of 2022. Women make up 21.57 million of the total, or 15%. The population within the United States. However, women's experiences, their lives, their health are for more than just a number. The Black and African American populations in the United States are actually far more diverse. 83% of its population is made up of non-Hispanic Black people. However, the larger Black community is also enriched and diversified by Caribbean, Sub-Saharan, or other Black or African American communities. Additionally, 3.356 million Black people are in Florida alone, around 1.8 million of them being women. The number of African Americans or Blacks are expected to rise to reach 60.6 million by 2060. According to the CDC, the US maternal mortality rate in 2020 was 23.8 deaths per 100,000 live births. And for non-Hispanic Black women, that rate increased 55.3 deaths per 100,000 live births. I know, that's a lot. This rate is 2.9 times the rate of non-Hispanic white women. However, Black women in the US are disproportionately at danger, particularly when it comes to something as basic as maternal health, even with this expanding population. What do we really mean when we discuss maternal health? It goes beyond conceptions of pregnancy and childbirth. The physical, mental, and emotional well being of a woman throughout her pregnancy, childbirth, and postpartum. This is referred to as maternal health. In a perfect world, all women would have access to the resources and the care they require to protect themselves and their unborn child. However, it isn't the case for a large number of Black women. Socioeconomic factors, including occupation, income, education, and social support, significantly increase maternal health outcomes. These are known as the social determinants of health, and Black women are disproportionately affected by these. And they lived in underprivileged or rural areas such as Florida. According to the graph, it shows in Black that women in Florida Black women in Florida face a maternity mortality rate that is significantly higher than the national average if we follow the line in the middle graph. Black women in Florida face maternal mortality rate that is underscoring the need to address the crisis. From years 2009 to 2019, the pregnancy-related death, or PRD, is the complication pregnant women face within a year of pregnancy. Pregnancy-associated death, or PAD, is the death of a pregnant woman that is within a year, regardless of duration, regardless of that site of pregnancy. Despite advancements in healthcare, African American women persistently face significantly high pregnancy disparity outcomes in Florida. There are 4 leading causes: thrombotic embolism, which essentially is a blood clot; hypertensive disorders or high blood pressure; cardiovascular conditions such as heart failure; and infections are identified as primarily factors contributing to these unfortunate fatalities in Florida, according to the Florida Maternal Mortality Review Committee, also known as MMRC. The situation is considerably more difficult for African American women in rural Florida. In Florida, numerous African American women encounter substantial obstacles that affect their maternal health. Restricted access to quality care, particularly in rural areas, hinders women's ability to obtain necessary prenatal and postnatal care. Elevated poverty rates intensify these challenges, resulting in a lack of resources for adequate care. Implicit bias in medical treatment frequently result in the minimization of pain and critical symptoms, therefore jeopardizing women's health outcomes. Moreover, insufficient transportation barriers to healthcare access hinders women's ability to attend appointments or obtain emergency care when it is essential. It is very necessary to address these barriers. Nevertheless, the maternal mortality rate in the US is higher than certain poor nations. This is particularly true for women of color. Poor maternal health outcomes are caused by a combination of low socioeconomic status, restricted access to healthcare, and racial discrimination in rural areas like Florida, where many Black women live. Among pregnancy-related deaths in 2020, 47% occurred 7 days to 365 days postpartum. Pregnancy-related deaths during pregnancy, delivery, and up to 1 year postpartum, the leading cause of pregnancy-related deaths vary by race and ethnicity. Over 80% of pregnancy-related deaths were determined to be preventable. Yes, I did say 80%. Even while these differences are concerning, there is still hope to address these disparities and enhance maternal health outcomes. There are some practical approaches. Improving maternal health outcomes necessitates the enactment of legislation that broadens Medicare coverage for new mothers, therefore ensuring access to comprehensive care irrespective of income. Furthermore, requiring implicit bias training for healthcare providers is crucial to address disparities for care and advancing equity for all women. Moreover, implementing rigorous standards for maternal care hospitals will guarantee that facilities deliver optimal care, emphasizing safety. Implementing these policies can establish healthcare that supports new mothers, address systemic bias, and ultimately enhances outcomes to perform a transformation, because now is the time. To improve maternal health, we must increase access to prenatal and postnatal care, especially in those underserved communities. Expanding healthcare facilities, mobile clinics, and insurance coverage will ensure that every woman has the support that they need during, before, and after pregnancy. Additionally, implementing standards, protocols, pregnancy-related complications will ensure consistency and safety across the healthcare settings. By setting clear guidelines for identifying treatment for complications, we reduce preventable risks and improve outcomes. These efforts will help create more equitable healthcare system where every mother receives the care she deserves, regardless of her background, location, enhancing the outcome and her outcome and empowerment to advocate for her health care through the provision of education resources that help build their confidence. Facilitating peer support networks enables women to exchange experiences, provide guidance, and collaboratively navigate healthcare systems. Collaboration with local organizations is essential for addressing social determinants of health for maternal health, including their housing, nutrition, and their transportation. Establishing environment that is willing to promote a community-driven solutions will equip Black women with the necessity that they need for the tools and resources to manage their health effectively, resulting in improved outcomes for themselves and their families. Local and national bodies among organizations like Florida Department of Health and Florida Senate can push for legislation that tackles systemic issues such as health disparities and racial discrimination. We need policies that ensure that every woman, no matter her race or where she lives, has the access to the same quality of care. Stakeholders play a critical role in improving maternal health outcomes. External stakeholders such as maternal providers, public health agencies, and organizations among the community, such as Black Mamas Matter Alliance, are essential for advocating for policy changes and providing education and support for Black women. Internal stakeholders include those mothers themselves and their families. They are directly affected by these policies and should be able to actively be involved in help shaping the healthcare policies in their practice. Extending postpartum Medicare from 60 days to 12 months is viable solution by evidence of effectiveness. More than 50% of states have implemented this extension by provisions from the American Rescue Plan. Nonetheless, obstacles do persist. States are required to obtain legislative support and ensure sustainable funding, a process that can be rather complex. Certain states exhibit a delayed adoption of the attributable. This is attributable to political discord or physical considerations. Legislative gridlock, frequently shaped by partisan divisions, may impede this process. These are challenges of the expansion that is essential for enhancing maternal health and sustained advocacy, facilitate the surmounting of these barriers. Healthcare systems reforms. Healthcare providers should require the training to help improve their cultural competence, particularly when interactions with African American women, to foster that trust and mitigate racial discrimination in healthcare. It is very important to implement cultural competence care models at hospitals and provide hospitals with ways to implement this. The level of feasibility of this solution requires time and funding and training for development. Barriers include they need to have the leadership buy into this, limited time for training, and resistance to cultural sensitivity initiatives due to implicit biases. Although process may be gradual, prioritizing this training is essential for enhancing healthcare experiences and outcomes for African American women. Therefore, cultivating an environment characterized with respect, understanding, and trust. Community-driven initiatives to address those social determinants. Implementing a community-based health education program is critical for equipping women with essential knowledge regarding prenatal care, nutrition, and mental health support throughout their pregnancy. Local nonprofits and faith-based organizations can effectively implement these programs by leveraging clinics, churches, and community centers that will provide adequate resources. Certain faith-based organizations, their health ministries provide and serve with transportation to facilitate women's access to the care that they need. Nonetheless, the primary obstacle is funding, which is frequently dependent on donations, federal or state grants, and this may lack that long term viability. Although the impact may be substantial, ongoing sustainable funding is essential to guaranteeing the continuation of these programs for the benefit of women and their infants. Furthermore, we need to make an effort to lower systemic and societal barriers that keep African American women from accessing proper prenatal care, safe delivery methods, and that mental health assistance that they need. What are our options then? We can provide Black women and all women of all races the best chance for safe delivery and healthy pregnancies in the future. This is by implementing essential prompt measures to enhance the maternal health outcomes in contemporary society. It is essential to improve the accessibility of prenatal and postnatal care, guaranteeing all women, no matter their background or geological location, receive the necessary health care before, during, and after their pregnancy. Culturally competent healthcare providers is essential for bridging that gap between medical care and the specific needs of the diverse communities, therefore fostering trust and enhancing care outcomes. Legislative support and policy change are critical for developing systemic solutions. Collaboration among those lawmakers and stakeholders, including healthcare professionals and community organizations, to advocate for affordable, accessible, and high quality care for all. It is essential to acknowledge the influence of socioeconomic inequalities that are happening in maternal health, mitigate economic disparities, including provisions of paid maternal leave and access to affordable childcare. This will alleviate the burdens financially that many mothers experience, enabling them to prioritize their health and their well being. It is very imperative that we unite, implement these measures, establish a system that supports all mothers and children, no matter who they are and their circumstances. Eliminating disparities in access, this will give our mothers, daughters, sisters the care and letting them know that they matter. The undeniable truth is that Black women are dying at higher rates, and these deaths are preventable. Imagine a story where Chrissy got the treatment that she deserved. Well, she is still around for her children. We must push for a change for maternal health to address those root causes of these disparities. This is not a Black issue. It's about equity, health justice, human rights for all women. Every woman deserves the right to quality care and the opportunity to bring new life into this world safely. It is time for action, for policy change, for a collective effort that ensures no woman is left behind in her pursuit of her health dignity, and her future needs to be bright. The future does not have to be grim as these statistics suggest. Thank you so much. I would first like to thank my Lord and Savior, who, without his presence in my life, none of this could be possible, would have never made it this far. I also want to thank my coach, Dr. Bodrick. She stuck in there with me. I know I'm a tough one. Thank you. And also to my SME, my subject matter expert, nurse practitioner, Veronica Daniels. Thank you so much for your expertise and all your support. And thank you to my family and my friends. Cohort 1, we did it. Thank you.
Greetings, you're muted still.
Thank you. Hello, my name is Afia Sayed, and today I will be discussing the nursing shortage and strategies for staff retention. So about a year and a half ago, my mom was hospitalized for 3 days. During those 3 days, nurses would come and go every few hours. I got to talking to one of them, and she said that she had just made her round to every patient on this side of the wing. Imagine how that feels as a patient, just being part of a rotation that your nurse eventually gets to. Doesn't feel good when you think about it, does it? Well, that's the reality for almost every nurse that works on the hospital floor. Apparently, this is normal. My mom's nurse was overwhelmed as she came in to take her vital signs, give her medication, and do her charting, and then boom, we hear the code being called in the hallway, and the nurse rushed to help the other patient. Data shows that nurses only spend 32% of their time on direct patient care, with as many interruptions as much as every 6 minutes. They perform an average of 72 tasks per hour and multitask 34% of the time, and 35% of their time is spent on documentation. During a 12.5-hour day shift, nurses spend 60 minutes communicating about a patient's care to other care team members while only spending an average of 12 minutes communicating with the patient themselves about their care. Patient assessments took around 38 minutes, with less than 5 minutes were spent on mental health assessments. Care planning took 140 minutes, while non-healthcare related tasks such as ordering supplies took up to 100 minutes. Now imagine having to do this much work for each patient. We would all be exhausted too. These administrative tasks take up so much of a nurse's time that they don't have enough time for actual patient care. No wonder nurses are so overwhelmed and burnt out. One time I went in for a massage. My massage therapist told me that she used to be a nurse. I asked her why she quit. She said that she hated the mistreatment from both patients and management. Uh, she Many of her patients were rude to her, even when she cleaned up their bodily excretions, and never even got a thank you. That's odd, considering that the Gallup 2024 report exemplifies how highly nurses are regarded in our community. The survey showed that 75% of public considers the nursing profession as one of the highest regarded professions for 23 years in a row. Yet nurses are leaving the profession altogether. They feel overworked and underappreciated. From 2020 to 2021, in the United States, 100,000 nurses exited the workforce due to job dissatisfaction and burnout. The American Nursing Association reported that the healthcare industry will need 1.13 million more nurses by 2028. That's only 3 years away. There are currently 2.75 million registered nurses in the United States, and this demand could rise up to 3.19 million nurses needed by next year. Now, this nursing shortage is nothing new. It did not start with the COVID-19 pandemic. The pandemic may have highlighted the severity of the issue, but the nursing shortage actually started with the Great Depression. According to the University of Pennsylvania, the nursing shortage was a direct result of the financial disaster of the Great Depression. This period marked the worst economic downturn in the United States history. It significantly impacted the healthcare field, with skyrocketing unemployment rates and a profound strain on healthcare resources. Even during the challenging times of the Great Depression, policies made significant efforts to address the nursing shortage, employing three key strategies: increasing nursing school admissions, reducing training time, and utilizing lesser trained professionals to extend nursing duties and create more jobs through the Nurse Training Act of 1964. The overall expansion of the nursing profession includes the creation of licensed nurse practitioners, LPNs, and certified nursing assistants, CNAs, to help address the shortage of hospital nurses. LPNs and CNAs fill the gap by creating shorter training programs so that nurses can begin working sooner, such as a few months to a year, rather than completing a full nursing degree to become a registered nurse. The LPN profession rose in the 1940s, initially starting as bedside nursing to assist registered nurses. However, as the healthcare field grew, LPN responsibilities shifted to outpatient care by the new millennia. The persistent nursing shortage faced a further blow as the United States was drawn into the two world wars. Nurses were called to serve into the military, creating an even more significant shortage as hospitals at home were understaffed and military nurses did not return to their former posts after service. This global conflict had a lasting impact on the nursing shortage, further exacerbating the situation. Hospitals in the United States experienced a shortage of nurses at home-based hospitals as they enlisted to serve in World War I. Therefore, during World War II, the U.S. government allowed married women to become nurses and work while their husbands served in the war. This allowance was monumental at the time when women were not allowed to work after marriage. Some stayed to fill the shortage at home-based hospitals, while others deployed alongside their husbands. This monumental phenomenon created a massive demand for professional nursing education, which led to establishment of nursing degree programs in universities in the United States after World War II. The need for wartime nurses in subsequent wars, such as the Korean War and the Vietnam War, drastically increased the duties and autonomy of nurses in the war zone. For example, during the Korean War, nurses were allowed to administer anesthesia for wounded soldiers who needed surgery. In the Vietnam War, nurses had the most autonomy as they single-handedly cared for wounded soldiers without any physicians present at the scene. However, this autonomy did not translate back to the U.S. hospitals. Nurses do not typically get to diagnose patients. They only follow orders from doctors, take care of patients, and take care of paperwork. This lack of autonomy was severely apparent during the COVID-19 pandemic as they relied heavily on the administration to support them. Healthcare workers were forced to work overtime, resulting in hospitals becoming overloaded with more patients than staff could handle. Nurse caseloads skyrocketed, compelling nurses to rush from one patient to another, unable to give everyone their undivided attention. This contributed to avoidable errors. Remember how healthcare workers begged for more personal protective equipment and other needed supplies? These limited resources created dangerous work environments, leading to burnout amongst healthcare staff. A study in Canada found that 92% of nurses experienced higher levels of burnout and a decline in mental health during the pandemic compared to before. Nurses left their positions due to burnout, frustration, and a lack of autonomy, while those who stayed began to quietly quit, performing only the bare minimum necessary. This behavior provided a misleading impression that nurses lacked dedication to their roles and were motivated solely by paychecks. However, in reality, they felt too overworked to exceed basic expectations. A survey conducted in the UK asked nurses what they would have liked to see during the COVID-19 pandemic that would have helped them. Many nurses responded with a timely, proper supply of personal protective equipment, better support for workers' mental health, better pay, better disaster pay, better communication between management and staff, including more explicit guidelines of expectations and listening to staff concerns, better management of workload, and to be given proper breaks and access to food and water. These concerns highlight the inadequacies of emergency preparedness in hospitals, especially if staff can't even get proper breaks to eat food, drink water, or even go to the bathroom. Nurses ranked their number one concern as staff safety and support for staff in the workplace. In the survey, 28% of respondents commented on the need to feel support for their mental health and well-being. Among the respondents, 28% reported being redeployed, with 9.4% coming from staff reassigned to a clinical area outside of their specialty. For instance, pediatric nurses temporarily switched to care for adult patients during the pandemic, and vice versa. Healthcare staff can only work effectively with adequate support. The American Nursing Association established that appropriate staffing ratios reduce mortality rates, length of hospital stays, and occurrence of preventable errors. Therefore, maintaining proper staffing levels is essential for patient recovery. According to the New York Nursing Association, Hospitals that staff 1 to 8 nurse to patient ratios experience 5 additional deaths per 1,000 people than a 1 to 4 nurse to patient ratio. Even the American Medical Association states that every additional patient per nurse increases mortality rate by 7% for all patients, as you can see on the screen. Additionally, a 1 to 10 ratio is unrealistic and detrimental to both nurses and patients. However, the U.S. Chamber of Commerce estimates about 9 nurses per 1,000 people across the U.S. If that's true, then each nurse would have to care for about 111 people. In some states, it's even less. For example, in the state of Texas, it is about 7 nurses per 1,000 people. That means that each nurse would have to care for roughly 142 people. How is this safe? This is where virtual nursing comes into play. Even if the nurse to patient ratio stays the same, the work for each patient would be less with virtual nurses, as they would take over the paperwork, cutting the workload essentially in half. Now, at the end of my mother's day, when we were getting ready to leave, the nurse was going over next steps in her recovery. When we were all done going over everything, the nurse said, "Okay, now I have to do the discharge paperwork. I'll be right back." Now, we waited for almost 2 whole hours before the nurse came back with that paperwork. The doctor decided that my mom was ready to be discharged first thing in the morning. We didn't leave the hospital until 2 p.m. that day. Imagine a world where bedside nurses didn't have to do that much paperwork. Sounds too good to be true, right? But that's where virtual nurses come into play here. Virtual nursing offers an optimal solution to address the nursing shortage, as it provides a practical application that hospitals worldwide can reasonably implement. The virtual nurse is assigned with several bedside nurses caring for patients. They watch monitors that show the patient similar to the look of a Zoom screen, except each patient has their own monitor. They also watch the results from lab tests, imaging, and monitoring devices. They perform all of the charting that bedside nurses normally do, making it possible for them to pay more attention to the patient. The transition to telehealth provided an opportunity for virtual care in almost every field of medicine. Many studies demonstrated that hospital stays increased longer due to an increased nurse to patient ratio, causing an increase in paperwork, especially discharge paperwork. Virtual nursing can streamline the discharge process to free up bedside nurses. The feasibility of virtual nurses' oversight at discharge will lead to bedside nurses delivering higher quality care, and patient satisfaction will improve as their discharge is accomplished in less time. Artificial intelligence can enhance patient discharge by creating an entirely separate discharge procedure. Virtual nurses, instead of bedside nurses, will solely streamline this process. By separating the paperwork and care coordination side of nursing, bedside nurses can focus solely on providing high-quality patient care. Studies show that nurses become overwhelmed and frustrated with all the paperwork and care coordination, including discharge, patient education, and coordinating after discharge care that comes with each patient. Virtual discharge was also proven effective at reducing readmission rates. Now, Perpetua did a study in 2023 that reported 3.23% of patients who received standard in-person discharge instructions returned to the hospital within 7 days of discharge. They also found a readmission rate of 1.12% among patients who received virtual discharge care instructions. If we had a virtual discharge option for my mom, we wouldn't have had to wait until 2 p.m. in the afternoon to leave when the doctor made the discharge call earlier that morning. This option might have even prevented her second hospitalization a week later for the exact same reason. Although the second time around, the EMTs took her to a different hospital and they took a different course of action that actually provided results. The second hospital had a different person other than the nurse coordinating her discharge care, which included outpatient appointments, so she wasn't hospitalized again after that. Nurses serve as the vital link between doctors and patients, providing care around the clock. Individuals enter nursing with compassion and genuine care and desire to care for others. Healthcare leaders need to listen and address nurses' concerns when they cannot provide adequate care. Too many nurses leave the profession because they do not feel appreciated. Nurses represent one of the most crucial professions in healthcare. Without them, the entire system risks of collapse. We need leadership to appreciate nurses by valuing their contributions just as they care for us in our times of need. Implementation of these solutions may come at a high cost. Establishment of a comprehensive department for employee mental health counseling and creating a virtual care team will require millions of dollars. However, the current cost of turnover will be offset with these strategies. Nevertheless, these changes are vital for our healthcare system's future. The current path cannot continue. The high turnover rates that plague healthcare organizations nationwide must come to an end. Stakeholders must define realistic and attainable expectations and goals. Both external and internal stakeholders should actively engage in building a robust infrastructure. Executive teams need to work with healthcare professionals to create safe working environments. The engagement of nurses is essential as they have valuable insights. Their experiences in navigating the challenges of this crisis demand attention. When nurses express the need for specific changes, implementing them becomes crucial to support them effectively. When leaders successfully satisfy their nursing workforce, retention will improve along with patient satisfaction. So now I just wanted to say thank you to Dr. Richens for being my coach and pushing me through this process. I would definitely have not gotten to this point without your support. Also, thank you to everybody else who have gotten me here and to my fellow classmates and cohort 1. Congratulations, we're here. We did it. Thank you.
Hello, everyone. My name is Rochelle Capers Johnson, and today I am going to talk to you about improving healthcare access, strategies to address the transportation barriers facing the aging population. Meet Grandma Patty. At only 69 years old, my grandmother was in trouble. She was diagnosed with cancer. She was very independent. She was a woman that did not want to burden you with her troubles. So she suffered in silence. My grandmother lived in a rural area, 40 miles away from the hospital and medical practices. There were no public transportation. She was limited on income. The closest child stayed over 40 miles away. No rideshare was invented at the time. And of course, she was limited in resources. After a few sessions of infusion therapy, my grandmother began to feel nauseous and fatigued. Even if she wanted to drive herself, she was not able to. So she missed out on a few appointments. And of course, her health began to decline. Doctor said she only had a few more sessions to continue with, but he had no idea transportation was a concern. The front office desk, they only reported that she was a no-show or had a missed appointment, but they did not follow up to really see what was the problem. I can remember my grandmother saying, "Sweet girl, I did not want to burden you all with taking me back and forth to my appointments. They were just so frequent." But she said, "I had faith that I would get over this." You see, in situations like this, my grandmother was not alone. In fact, in 2021, the Bureau of Transportation Statistics reported that 11.2 million individuals 65 and older living in rural areas are faced with limited transportation outside of their homes. In further research, the Census Bureau identified Americans 65 and older growing 5 times faster than the total population. This bar graph illustrates the growth of the aging population and the rising number of households with an annual income below $25,000. Therefore, an overview of this presentation will focus on transportation barriers, its correlations to social determinants of health, and to propose some solutions. As a healthcare community and system, we have to look at this population historically and holistically to understand what other factors are impacting the health outcomes of this population. Transportation isn't easy. You have geographic barriers. This aging population, there are some that are in the rural area with no specialty care nearby, undeveloped regions, and of course, public transit is either scarce or non-existent. Think about it. What if your doctor's office is miles away and you have no transportation and you're aging with an illness? What do? Yes, rideshare is an option now. But when it gets too expensive, you're dealing with economic constraints. Those that are, again, on fixed incomes. Rideshare's cost is increasing. And even if this aging population decide to drive their own vehicles, they're dealing with the maintenance and repair costs. Talking with Mr. Al here, he stated if he had to choose between going to the doctor's office or purchasing groceries, he said healthcare takes a back seat sometimes. You see, mobility issues makes it harder. Think about those that are living in rural areas and the urban area. They're faced with some challenges. Those that are in the urban area are faced with walking long distances to bus stops. The aging person who may have a temporary injury of chronic diseases, impacting both their lower and upper functions, requiring them to have an assistant device such as a walker, wheelchair, a cane, or a scooter. Consider the infrastructure deficiencies, such as a sidewalk when walking up long ramps. In addition, you have to think about those that have arthritis or impaired vision. It makes it very challenging to use mobile apps with ride shares. Next, we have limited transit options. Bus stops are delayed for those that are living in the urban area. And then, of course, if they're using the public transportation, you have some bus stops that don't even drop you off right at your destination. So they're again forced to walk. You have some bus crowding where the aging population don't even have enough room to sit down. And not every ride share is wheelchair friendly. The local paratransit services are limited with on-demand service availability and routes. In further research on aging and the health population, this figure identified factors concurring with the problem. Part of the 40% social economic factors is income. With lower income, it often leads to limited access and preventative care. 10% is physical environment, such as those living in unsafe, unhealthy environments with limited resources. And then, of course, you have 30% health behaviors. Individuals who may struggle to maintain healthy diets, perhaps due to income or their environment. And of course, this is causing 20% health care access and quality care delays. What can we do? If we want our aging population to stay healthy and independent, we have to do better in expanding affordable, accessible, and reliable transportation. because it isn't just a convenience, it's a lifeline. This issue falls under social determinants of health, the non-medical factors influencing the health outcomes, such as safe housing, food security, education, economic stability. And experts are now catching on. In October of 2022, the ICD-10 Z59.82 code was introduced, recognizing transportation insecurity as a real health barrier. In research, the feasibility study identified 3 barriers. The first is policy implementation concerns is a priority. For example, policies may conflict with existing federal, state, or local laws, causing a barrier for funding. Next, you have healthcare system reforms. It's also at a high, dealing with balance, affordability, accessibility, and provider capacity. This barrier is a commitment for government and local stakeholders to reform these issues. Next, you have the non-emergency medical transportation and paratransit services are also at a high, dealing with funding, service availability, and scheduling delays impacting feasibility because of the sustainable funding. So now we have some feasibility strategies. When we think of policy changes, one way to improve transportation for this aging population is through new laws that expand on services tailored to their needs. These policies should ensure fair funding, promote social inclusion, and make transportation options more accessible. Healthcare system reforms, we can do this by improving care coordination between healthcare facilities and community resources. This is done by integrating the transportation planning into healthcare services to reduce missed appointments. And then, of course, we want to be able to enhance paratransit services, which offers on-demand and flexible transport options for individuals who are unable to use traditional public transit. You see, these strategies create a more efficient, exclusive, and patient-focused healthcare system. But policy cannot be the only answer. We have to get into proposed solutions for collecting the data. So step 1, we need to first educate and train our providers to screen and collect information on social determinants of health. Step 2, we want to document any risk factors in a patient's electronic health record. Step 3, we want to be able to map the clinical notes to a Z code. Step 4, use the data to trigger referrals, to track the referrals between providers and social services. Step 5, report quality measures annually to target interventions in order to improve on these outcomes. Here's a call to action. As I mentioned before, we want to make sure that we're educating our healthcare providers, our healthcare teams to identify and address the needs, screen the patients for social barriers. We need targeted strategies for social determinants of health, utilizing CMS reporting tools. We want to be able to strengthen support networks, connecting high-risk patients with navigation services and community resources. We need to be able to expand transportation access. To do that, again, is to strengthen the programs. We need agencies and providers to partner with Medicaid, non-emergency medical transportation, Uber Health, Lyft, along with the Department of Transportation Services and also aging services within the state. More importantly, we need a collaboration with insurance companies to integrate transportation into care. Telehealth and virtual clinics is a wonderful platform. However, most of this aging population are dealing with the challenges of technology, navigation literacy, and many more. So, starting today, let's build a system where transportation is never a barrier to accessing care. Thank you. I would like to say thank you to my coach, Dr. Baldrick, for your support and for assisting me with my capstone. Importantly, thank you to my SME, Dr. Miriam Burnett. Thank you for your leadership and your guidance. To my mentors, my circle of strong women, my cheerleader, my mother, you are always lifting me up in prayer. Thank you for believing in me. To Militia Brown, I would like to thank you for always walking me through the process, supporting me through my efforts. Thank you to my family, to Ray, to my children, for loving me and understanding this mission. And overall, to my beloved grandmother, you will never be forgotten. I will continue this mission to further educate, research, and advocate to the DHA Cohort 1. Congratulations, we did it. Thank you.
All righty. Good evening, everyone. As we close out our final night of solution-focused capstone oral presentations, I want to take a moment to congratulate our DHA scholars. Ariana, Afia, Rochelle, congratulations on your presentation tonight. Your dedication, your research, and your innovative problem solving has truly shined, and we appreciate the hard work that you've put into developing impactful solutions. Well done. Now, we will transition to the Q&A portion of our session. To our audience, if you have any questions, please take a moment to submit them in the chat. I'll be reading questions out loud for our scholars to address as they come in. Wonderful. I don't think we had any questions, but we had a lot of congratulations and accolades. So again, congratulations, ladies. That concludes our Q&A session for this evening. Thank you so much again for your outstanding work. Your presentations have demonstrated the power of research-driven solutions, and we're excited to see your impact and contributions to the healthcare sector. Thank you to our audience for your thoughtful engagement throughout this series. At this time, I'll turn it over to Dr. Baldrick for her closing remarks.
Thank you, Dr. Miles. Good evening and congratulations to all of our scholars. As we bring our final capstone presentations to a close, let's reflect on the incredible work we've witnessed from our inaugural cohort. Each of our scholars has demonstrated not only the depth of knowledge, but also the passion, the dedication, and innovative thinking that is required to address real-world issues that we face in healthcare today. The Doctor of Health Administration Capstone Project represents more than just an academic milestone. It is a testament to the commitment to transforming healthcare delivery, improving patient outcomes, and shaping the future of healthcare leadership. To our scholars and our inaugural cohort, as you move forward, I encourage you to continue asking the big questions, continue pushing boundaries, and striving for health equity and health justice. Your capstone experience has concluded, but your journey as a healthcare leaders is just beginning. Congratulations once again on your remarkable achievement. We are so proud of each and every one of you. To our audience and to everyone who has supported our scholars and our program, we thank you. Have a wonderful evening.